It is my pleasure to introduce our guest speaker for today, Dr. Craig Reigel from the Virginia Orthopedic and Spine Center in Culpeper, and his office manager, Michelle Earnshaw, who was very helpful in getting Dr. Reigel here on time. Dr. Reigel routinely treats many orthopedic injuries and performs various procedures, including total shoulder replacement, rotation cuff repair, orthoscopic meniscus, ACL repair, and carpal tunnel release. He is board certified and is a member of the Culpeper Hospital medical staff. Before joining the Virginia Orthopedic and Spine Center in 2003, Dr. Reigel worked in private practice in Philadelphia, Pennsylvania, where he had the opportunity to provide services for several high schools, collegiate, and professional sports teams, including the Philadelphia Phillies, Flyers, Eagles, and Wings. Dr. Reigel holds a master's degree in physiology from Temple University, a medical degree from the Medical College of Pennsylvania, sports medicine training from Thomas Jefferson University, and the Alma Marani Prize for Excellence in Internal Medicine. But the one Michelle's most proud of for him is Dr. Reigel has been awarded an award for most punctual doctor. No waiting. Dr. Reigel, we welcome you.
All right, thank you. So our topic is going to be shoulder pain. So if there's any questions or you want to stop me for any reason, please don't hesitate. There's plenty of spots up here if the slides are a little too distant, so move forward if you can't see. So we're going to talk about a couple choices with shoulder pain. First of all, kind of break it into two groups and spend most of our time talking about two chronic problems, arthritis and rotator cuff pathology or problems. But to touch on a few acute problems, yeah, you can injure your shoulders in lots of ways, from trauma, whether it be high energy injuries or simple falls at home, or doing crazy things like this. So you can dislocate your shoulder, where the ball pops out of place. So there's the ball in place, there's the socket, there's the ball and socket of your shoulder. That ball belongs there. And so you can separate your shoulder. If people have heard of separations, that involves the joint where the collarbone meets the shoulder blade. So this belongs there. So you're disrupting the ligaments around the AC joint. And can be cosmetically a little disturbing, but actually usually heals and does pretty well. You can also break a lot of the bones around the shoulder, whether it's the clavicle or the scapula. The scapula or the shoulder blade is actually less common. It takes a lot of energy to break your scapula. But proximal humerus fracture, so the upper part of the humerus, which is the bone in your arm, that's the ball and socket, can be fractured. And more commonly, a fracture from osteoporosis. So we see these fractures commonly in the elderly. And the proximal humerus can break into 4 different parts that we describe: the articular surface, the ball, the shaft, and then there are these 2 bumps called the tuberosities, the greater and lesser tuberosity. So we describe those fractures in 4 parts because those pieces have attachment sites, and so when you break it, those muscles can shift the bone in different ways depending on what part got broken. And how we address that depends a lot on how displaced it is and how many pieces there are. Most of the time, surprisingly, those fractures can be treated conservatively, meaning sling for comfort, and we start early motion, and they heal pretty forgiving fracture. So the majority of them do not require surgery. So here's a proximal humerus fracture where the surface of the ball is no longer even facing the socket. The tuberosities are off here to the shaft. So that's a displaced 4-part fracture. Here's a 3-part fracture where it has the ball again isn't facing the socket at all. The greater tuberosity is off. The lesser tuberosity is still attached, and then there's the shaft. So you have 3 pieces. And you can push this back in place and pin it, which sounds easy, but is actually a very difficult thing to do to get pieces back in place. And he's talking about this pin that goes all the way up his... but the pins get removed later. Or we can put things back in place with plates and screws. So now you're talking about a bigger incision in surgery. Or if things aren't really fixable, we actually take the broken ball out and replace it with half of a total shoulder. Total shoulder means that you replace the ball and the socket. Well, there's nothing wrong with the socket, so we would just replace the ball. That puts a lot of pull or strain on the tuberosities where there's muscles attached. So a third choice that we use more recently is a reverse shoulder replacement. We're going to touch on that later when we talk about rotator cuff problems. But we reverse things. The ball used to be over here, and then the socket over there. Now we put the ball on the socket side and the socket on the ball side. That's what it means to be reversed, a reverse shoulder replacement. And it has to do with taking the strain off of the attachments of the rotator cuff. And we haven't talked about rotator cuff yet. We're going to talk about that later. So we're going to spend most of our time talking about things that really don't happen from an event or an injury, or they happen from chronic injuries. Obviously, it can be from more strenuous sports, but it can be from even activities of daily living where you can wear the shoulder out. A lot of people come to me with, say, rotator cuff tears, and they talk about an event where they started a couple weeks ago. I was lifting or I fell, and it started then. And you can look at rotator cuff tears and really know that it's been there a long time. So a lot of times it's a chronic problem that you've kind of been ignoring, and then there's an event that makes it worse or aggravates it. So there's the chronicity of the injury is always difficult to determine sometimes. So when is it really time, if you have this chronic injury that's been going on for a while, when is it time to seek attention for it? Well, the first is if there really is an acute event. If you fell and you're having a lot of pain, yes, you could have a fracture, yes, you could have a dislocation, or there's other problems that we talked about, and you should have it looked at. The second is if there are other symptoms involved, particularly with left shoulders, we commonly have referred pain from other sources, cardiac. Are you having shortness of breath? Are you diaphoretic or sweaty with this? Are you having chest pain? So shoulder pain can be a sign of other problems. We see right shoulder pain sometimes with gallbladder problems. Again, other symptoms can be a sign of a bigger problem, and you should seek attention if you have those other symptoms. And then the last thing is, with these chronic problems, Usually, I hurt this, I was pruning, and now my shoulder is sore, and I stopped pruning, and hey, my pain got better. Great. Well, if you didn't get better with just modifying your activities, avoiding the things that hurt, if that's not working, yeah, you should have it looked at. So there are a lot of sources of shoulder pain. We're going to focus on two, involving the rotator cuff and the joint surface. So first question is, what is the rotator cuff? People have heard about that, and they don't really know what that is. So just give you a little anatomy. So we skin this guy, and we look at the first set of muscles, which is that deltoid, which is this big muscle. So if we take the deltoid out of the way, around the shoulder blade, there are 4 muscles that go around the ball and socket. Those 4 muscles are the rotator cuff muscles. The rotator cuff is a set of 4 muscles around the ball and socket. There's one on top that goes underneath that bone and attaches over here to that bump that we talked about earlier, that greater tuberosity. There are 2 in the back, and there's 1 that goes across the front. So 4 muscles around the ball and socket. That's the rotator cuff. Now, of those 4, top one, the one on top is the problem one 90% of the time. So that's the one we'll talk about most. You can tear any of them, but again, 90% of the time, it's the supraspinatus, the one on top, that's the problem. So you can overload the rotator cuff with one event. If you dislocate, where the ball popped out of place, you yank on those rotator cuff muscles, and it can tear. So it can happen from one big event. But more commonly, it happens from chronic overuse or, like I said, even just routine activities of daily living. You say, well, why would that happen now? Or why would that happen? It didn't happen when I was 20. Why would I tear my rotator cuff now? A couple problems. One can be the blood supply to that tendon isn't as good as it was when you were 20. So when you were 20, if you did overuse it and it got partial tears, that tendon was able to heal and be back to normal fairly rapidly. Now it takes a little longer. So these little partial tears didn't heal all the way, and then you stress it again and again, and then it can be additive and really cause a chronic tear to it. So a lot of the rotator cuff tears are not an event. They're gradual onset. It also has to do with the muscle imbalance, and that's something that we can correct with therapy, and we'll talk about that when we talk about some of the treatment options. So with the rotator cuff muscle on top, that supraspinatus, the problem is kind of a progressive deterioration over time. And the first thing, as we raise this arm up, that bump, that bone there, can bump into the bone above. And that's called impingement. And in between those two is that rotator cuff muscle on top. So first there's a bursa, which is kind of a lubricant. It's a fluid-filled sac. And it gets inflamed, so you can call it a bursitis. And then the tendon becomes inflamed, so you can call it a tendonitis. And then the tendon becomes frayed or partially torn. I always tell people it's like a worn out hole in your jeans, where it gets a little frayed, a little threadbare. And then it can tear away. And as it tears away, now the muscle is still pulling on that, so gradually over time, the tendon retracts, and the tear gets bigger and bigger and bigger. The other problem that happens is that if you have detached the muscle from one end, you can't use that muscle now. You can't pull on the muscle. What happens when you don't use your muscles? They shrink, they atrophy. And that atrophy can be a real problem because a lot of times it's permanent. We don't really know why that is. You think if you surgically reattach it, and you work on exercises, that atrophy would go away. It doesn't. So some of that atrophy will be permanent, and so it's the bad prognostic indicator if we see a lot of that atrophy before surgery. And so that changes what we'll do surgically also. And the last thing is that these muscles are important for controlling the position of the ball and socket. Without the rotator cuff, if you have a big hole in the rotator cuff, it changes the mechanics of the ball and socket joint. So the ball tends to slide around in there more rather than rotating nice and smoothly on the socket. That abnormal motion leads to wear of the surface. And that surface wear is what arthritis is. So first we have a bursitis, tendonitis, partial tear, then a full thickness tear, then retracting and becoming a large tear, and then changing mechanics causing arthritis. So here's a picture of the rotator cuff, that one that comes underneath, and it rubs against that bone above, creating a tear in the rotator cuff. What do we do about it? But how do we diagnose it first? So most of the time we can judge whether it's a partial tear versus a complete tear by exam, but you can get fooled. So a lot of times we'll start treating people for partial tears, tendonitis, or bursitis, which is non-surgically first. And if that fails, then we send them for an MRI. So this rotator cuff muscle belongs attached over here, and there's a hole here. That hole we can see on an MRI. The MRI is a very nice test where we can see the soft tissue that you can't see on a plain X-ray. So it's a great test. It's, in this case, non-invasive, but it means that they don't stick anything in you, which is good. It's not radiation. X-rays aren't particularly good for you. MRI is not. It gives us great pictures of soft tissue. Sounds great so far. The downside of the MRI, it's a $2,000 test. It's very expensive, so insurance companies will say, wait a second, we don't want to pay for that yet. Again, they may even want you to see how you do in therapy first before they say, all right, we'll pay for it now. But it gives us great pictures of the rotator cuff. So the initial treatment, again, for that early phase of rotator cuff problems is non-surgical. We control pain with anti-inflammatory medicines. We can ice after activities. But the most, and we want to avoid things that hurt. So if certain things really are causing pain, avoiding them, allowing that tendon a chance to heal is important. Cortisone injections, quick fix, it makes it feel better by the next day. And so it can make you comfortable enough to do the exercises. And the exercises are what is the most important part. But you want to use them sparingly. Cortisone is actually not really good for the tendon. So, especially if there's multiple injections. So, again, use them sparingly. But the most important part of the treatment for the non-surgical treatment for rotator cuff problems, exercise. Now, why would exercises help? It has to do with the muscle imbalance or what that rotator cuff does. It helps to hold the ball down and centered on the socket. When you have a rotator cuff that's not working very well, the ball rides up and it rubs that already irritated rotator cuff even more. So the problem kind of perpetuates itself or even gets worse over time. So we want to reestablish the normal rotator cuff strength, depresses the ball, gives the muscle on top more space so it doesn't rub, so it has a chance to heal. Okay, so again, that's the most important part of non-surgical treatment. Okay, let's talk about surgical options. When is it time for surgery? Well, with bursitis, tendonitis, partial tears, it's when non-surgical treatment has failed. How long do we wait? 3, 4, 5 months of doing an exercise before we wave the white flag and say, hey, we're not making progress here. So we really want to see that fail. But if you have a complete tear, that's not going to be getting better. In fact, over time, the tear gets bigger. So that is something that we tend to fix if you have a full thickness tear. So let's talk about some of the surgical options. So deciding what we're going to do to take care of a rotator cuff tear depends on these things. Number one, how big that tear is. At some point, that tear gets big enough where it's no longer repairable, right? So it retracts and we can't close that hole anymore. Secondly is that atrophy issue. That's permanent. So if you have significant atrophy, it can be a problem as well. If you have arthritis, and I fixed the rotator cuff, you still have the arthritis. And so you'll still have pain. So those issues will change what we want to do for a rotator cuff tear. Okay. We used to, 20 years or more, arthroscopically look inside, see a rotator cuff tear, and then open it to fix it. So the majority of rotator cuff tears were fixed open. Now, for the most part, we fix all of them arthroscopically. So this is looking in surgically through an open incision, and we can see at the top of the rotator cuff, this hole doesn't belong there, and this is the repair. But we can't see anything else. We can see that rotator cuff, and we can repair it, but you're not really looking inside of the ball and socket. I'm not seeing the biceps, the labrum, the surface, other structures. So arthroscopic repair has the big advantage of being able to see other things. I can actually see the rotator cuff tear better arthroscopically than I can in open, and I can see other structures. It hurts less. There's usually 4 little holes. Usually I tell people the holes are about the size to fit a pen through. And to do it open, sometimes you detach that big muscle, your deltoid. Well, that's more painful and slows your rehab. So arthroscopic surgery has the advantage of rehabbing a little bit more rapidly. So again, I am a big proponent of doing all of them arthroscopically. We'll talk about the arthroscopic complications, but the risks are very low. So again, we're working through little holes with a camera and a light source, and we're working usually again through 4 different portables. I choose a beach chair position, so this patient is sitting semi-reclined. Doesn't sound like he has a umbrella drink in his hand or taking it easy there, but small portals, and here we are looking inside the ball and socket. So the ball's here, socket's here. There's a rib around the socket called the labrum, and there's a little frame here, and we can trim away that frame. Is that really why you're there? No, but you can take care of other problems at the same time. This is the biceps, so that your biceps goes right up over the ball and attaches to the top of the socket. And there it is attaching to the top of the socket, and it looks wonderful. So you can look at that and make sure it is not torn or a problem. Then, if we stay on the view on the upper left here, that's still in the ball and socket. There's the biceps exiting, and if we look up, there's the rotator cuff tear. That edge belongs attached over there. Now the pictures that we've seen so far are all in the ball and socket. Now we can go above the rotator cuff and look down on it. Now we're looking down on it. This edge belongs attached here. So that edge belongs attached there. And so here's after the rotator cuff repair where that piece is sewn back down into where it belongs. And again, that's all done arthroscopically. The knots are tied arthroscopically. So those first three complications, almost unheard of. Blood loss is minimal. I've done over 1,000 arthroscopic rotator cuff repairs that have 0 infections. Infections are always a possibility, but pretty low risk. Are there any major nerves or blood vessels in my way? So pretty safe operation from that standpoint. The length of the surgery has a big variability. Typically it's about an hour and a half. So it means an hour and a half of a general anesthesia. So you have to be healthy enough for that. There are 2 other big problems with rotator cuff repairs. If we repair that tendon and then keep you perfectly still while that tendon heals for 6 weeks, we end up with a healed tendon and a stiff shoulder. So we want to get you moving early. The second problem, recurrent tears. So we're sewing sometimes through bad material. Again, I'll liken it to a hole in your jeans. You have a frayed hole in your jeans, and if you're sewing through the bad material, it can re-tear. We're also sometimes pulling that tendon under tension back over to where it belongs. And so it's under tension, and we're sewing through bad material, so recurrent tears are a problem. About 20% of the time, fairly high. And so we want to get you moving early to stop stiffness, but we don't want to have a recurrent tear. So usually people are in a shoulder immobilizer for a whole month, but they take it off daily for some exercises. The exercises are what we call passive range of motion. Passive means that they're not really using that muscle. They're not pulling on that muscle to move it, but they're just using gravity or having a therapist move their arm to maintain motion.
Doctor?
Yep.
What do you do when there is a recurrent tear? Do you go back in?
So usually our best shot at repairing it is going to be the first time. But do we try again sometimes? Yes. Sometimes we can change how we're fixing it, or even partially repairing it sometimes improves function. And then we start talking about the other choices if it's not repairable. So it kind of depends. It also depends on, is this your dominant side? Are you in your 50s? Are you in your 70s, 80s? And activity-wise, what do you want to do? So there's some choices there as well. So, what if you don't have a repairable rotator cuff? If you're young, less than 40, and you have a unrepairable rotator cuff, which is unusual, but it happens, we can take other muscles, either your latissimus or your pectoralis muscle, and move it to make it act like a rotator cuff muscle. Big open surgery, and something we only do for a younger person that may have multiple years on their shoulder, and then we want to give them a little better function. So muscle transfer. I mentioned a partial tear. If you can repair the rotator cuff somewhat, it improves the function and can give you a more normal shoulder. There is also a new procedure called a superior capsular reconstruction that's been out for less than 5 years, and it's a way of putting a piece of allograft, which is from a cadaver, and it kind of reconstructs a rotator cuff-like tissue that holds the ball and socket back in place. I would use that for the 40 to 50-year-old person. The last is a reverse shoulder replacement. Now you're talking about a big surgery versus the arthroscopic surgery. We're gonna talk about that a little bit more. So, as I mentioned, if you don't have a rotator cuff, it changes the normal motion in your shoulder. It allows the ball to ride up out of the socket. Here's the ball. Over here is the socket. So the ball is kind of higher than it should be. And with that abnormal motion, it's worn out. There's no joint space here. The white cartilage in the joint is gone. If we did a traditional shoulder replacement, the ball would still want to slide up there. And that can cause problems. So again, we replace the ball and socket by switching them. So we put the ball on the socket side and the socket on the ball side, right? And what that does is it holds that joint in place, allows you to move it, but it doesn't allow it to slide up out of place. Okay, so it's designed to not have a functioning rotator cuff. And that's been around, that was around for 25, 30 years or more, and it failed. And then they redesigned it, and we've reintroduced it over the last 10 years. So it's been something that we've used significantly over the last 10 years. So it's been a great help for it.
There's a question.
Sure.
I'm going to go back, but you talk about rotator cuff tear. To me, a tear, partial tear, they're apart. How in the world, through exercise, does that come back together? And I don't understand how that would, and what is the strength of that area after you go through that exercise program?
So, a good point. So, when I'm saying partial versus full thickness, when I say partial, it's frayed, it's worn, but it's still attached. That can heal. If it's torn away, that's the full thickness tear. That means it's not going to heal it doesn't jump back over there. But that's a good point. The full thickness tears are not going to really heal with the therapy. The partial tears can. All right, so that's a big distinction.
But what holds that together?
So the idea behind the non-surgical treatment with exercising is if I have this partial tear, it's frayed from rubbing against this bone above, but I work on strength that depresses the ball. Now I'm raising my arm up and it's not rubbing anymore, the tendon has a chance to heal. So it's basically eliminating what's causing the tear, and then it just allowing the tendon to heal. Does that make sense?
Yeah, I guess so. No, the muscles though.
Yeah.
There's muscle tear.
It's not complete
tendon tear,
though.
right?
It's not torn completely though. It still has an attachment.
Do you get full strength back through exercise?
Yeah, you can, yes.
So you're actually growing new tissue then?
It's a tendon that's healing. So if you had a frayed Achilles tendon that can heal, or other tendons, they can take a while. But yes, it can heal.
What do you mean by a while?
So, months. Like I said, people do the exercises 3, 4, 5 months before we say, hey, this isn't working. So it can really take that long before you say, hey, I'm making progress and I'm getting back to a normal shoulder. So it can be a long time with a partial tear. If you have a complete tear, that's when we kind of say, you're going to do better having it surgically repaired. But partial tears, tendonitis, bursitis, they can get better with exercises alone.
And the doctor has to tell you then, due to what the MRI says, whether you have a
Right.
partial tear or...
Or by exam. Sometimes you can tell by exam. So.
Is there an exercise that's bad for the rotator cuff? I was thinking about doing push-ups. But what I'm watching here is push-ups are dangerous.
Well, so there's a lot of exercises that do strain the rotator cuff, usually above shoulder level. So it's like military press or things above your shoulder. Sometimes push-ups also will aggravate that. So what I tell people, if you're doing exercises, if you do a push-up and it hurts, then you probably shouldn't be doing that. If it hurts afterwards, I'm okay with that. But if it really hurts while you're doing it, that's probably not a good idea. So listen to your shoulder, but there are certain exercises going to be more stressful to a rotator cuff, particularly above shoulder level activities. All right.
Dr. Reigel?
Yes.
Above shoulder exercises, pushing up is not good, but what about when you're
Pulling down like a lat pull.
Yes,
Sometimes you still impinge, so as you go up, you're still taking that ball and rubbing against the bone above. So again, it's not as bad as doing, or usually not as stressful as doing a military press, but it still can be.
now if
So
you're not
again,
feeling any pain at all while you're doing that,
listen to your shoulder. If it hurts, I wouldn't do it, but otherwise, it should be okay. Yep. All right, we're gonna move away from rotator cuff. We're okay with arthritis. So when I ask people define that, what is arthritis? They usually have a hard time. So arthritis, if you look at the end of a chicken bone, has that white cartilage. Both sides of the joint have that white cartilage, and it's a nice, smooth, slippery surface. When that white cartilage wears out, that's what arthritis is. It's the wearing out of the bearing surface of the joint. Now that can happen from a lot of different causes. It can be from inflammatory type arthritis, where it's a systemic disease that causes inflammation, and the inflammation damages the surface and leads to wear. Or it can be osteoarthritis, which is sort of a wear and tear arthritis. We can also be from other causes. If you have damage to the surface from a previous injury, it can wear abnormally and cause arthritis. If you have rotator cuff tears and it is leading to that abnormal motion, it can cause the surface to wear. And the last one there is avascular necrosis. Avascular means no blood vessels. Necrosis means something died. Means the ball died. And the ball can collapse. Now you have an unround ball in the socket. It can rub and wear and cause arthritis. So there are a lot of different causes for the wear of the surface, but the most common, osteoarthritis. And we're mostly talking about the ball and socket joint. You can also have arthritis in the ACG joint. That's where your collarbone meets your shoulder blade, that little bump on top of your shoulder. Almost everybody over 40 has some degree of arthritis there. We're talking mostly about the ball and socket. The arthritis in the AC joint usually is asymptomatic. People don't usually complain of their AC joint too much. So the diagnosis for osteoarthritis is a little bit easier. We can usually make that a diagnosis with exam and with simple x-rays. So what are we looking for on an x-ray? There's the white cartilage that wears out. The white cartilage that wears out, we can't see on x-ray. But we see a space where it belongs. So as it wears out, the space between the ball and the socket disappears. So one thing we look for is the joint space. There's no joint space here. The next thing that happens is that the bones around the arthritic joint react to that, and they form bone spurs or osteophytes, and the bone gets denser, so it gets this darker, or not darker, this whiter area, and this big bone spur down here is pretty typical for osteoarthritis in the ball and socket joint. So initial treatment is we want to maintain your motion and strength. When it hurts, you don't want to use it because it hurts, and they tend to get stiffer and stiffer, so you want to maintain motion. We try anti-inflammatory medicines. Obviously, they work great at controlling arthritic pain. They do have some complications. They can affect your stomach and cause GI bleeds. They can also affect blood flow to your kidneys. So if you have renal failure, it can aggravate that. But otherwise, fairly good medicine is at controlling arthritic pain. if you go to the pharmacy, there's this whole section of all these dietary supplements, glucosamine, chondroitin, there's a whole bunch of them. We've really shown very little evidence that they make a difference long-term. At either having the surface regenerate itself or slowing down the arthritis. They do, some of them do have an anti-inflammatory effect, so they do make it feel a little better, but long-term, do they make a difference? Probably not. Cortisone injections, again, like the rotator cuff, quick fix. Next day, feels pretty good. Two downsides. Number one, it's temporary. We don't know how temporary. Sometimes they last several months, sometimes it's less than a week, and they tend to deteriorate over time. So you may get one and it worked for several months, and the next one worked for a month, and the next one works for a week. So it won't continue to do great. The second downside is that multiple injections aren't really good for the joint. Just like they weren't really good for the rotator cuff, they're not really good for that articular surface. Use them sparingly. When it's really flared up, you can try that to control your pain. Let's talk about some of the surgical options. Orthoscopically, we can look inside, clean up the surface, so when that surface wears, where's it go? It creates debris in there, and we can have loose pieces, and I can clean that up. But I can't resurface it. So orthoscopic surgery has very limited benefit. It helps a little bit and temporarily. So not a great choice. The others are all open surgeries where we're replacing the ball in the socket. And they all have their pluses and minuses. The reverse rotator cuff, as I mentioned, has the big advantage of not requiring a rotator cuff to function. So if you have arthritis and a partial tear of the rotator cuff or a complete tear of the rotator cuff, that could be a good choice.
What's the most common surgery?
For the most common would be a total shoulder, which is, we'll show you that. So here we are, here's the arthritic joint, again, no joint space, big bone spur. Some people would replace just the ball, leave the socket alone. Well, you can still have pain from the worn socket. So again, I'm not a big fan of that. You can replace both sides. I replace the socket and the ball. And that's a total shoulder replacement. So the ball is actually modular. We can change the size of that ball, make it thicker, make it wider. And the plastic, there's a piece of plastic that is the socket. That is a total shoulder, and that's the most common, commonly used for osteoarthritis. We usually will have, not usually, we have both on the back table. So if I'm planning a total shoulder replacement, which means we want to have a rotator cuff that's functioning. If we look inside and go, oh, we don't have a rotator, this rotator cuff is torn, we can switch to a reverse shoulder replacement. It's the same approach. The equipment's a little different, but we have it on the back table ready for us. Okay, so we can change your mind in the surgery from total shoulder to reverse shoulder, all depending on whether the rotator cuff is intact.
What's the life expectancy of a plastic cuff?
So, what wears out? The plastic.
Yes.
So, the plastic is what wears, and the plastic is not your garden variety plastic. It's highly engineered, that the molecules in the plastic are cross-linked so that they don't wear very much. And that's really changed over the last 15, 20 years. So the plastic's pretty good, but it still wears out. How long does it last? The best indicator of that is who you put it in. All right. So if you want to do a little gardening, you have a bowling league in the winter, it can last you 25 years or more. If you're a young guy and you want to go out and play a little tennis, or you have a job that's more strenuous, it can last maybe 15 or less. So it really depends on how you use it. A little different than a weight-bearing joint like a knee or a hip, but they still wear out. Big surgery, so bigger complications. Most people don't require transfusions, that there is some, there can be significant blood loss. Rarely do we need to transfuse people for a shoulder replacement. Infection rate, the infection rate for a shoulder replacement or for all joint replacements are relatively low, less than 1%. Consequences are high though. So what do I mean by that? When you have a big piece of metal in there, it's a big foreign body. If it gets infected, sometimes we have to take it all out, cure the infection, and then put it all back in. So 2 more big surgeries. So we do take some extraordinary precautions. We wear a special suit, looks like we're on the moon. We give you antibiotics, and the risk is low. But again, the consequences can be high. Nerves and blood vessels, there is an important nerve, both for the reverse shoulder and for the regular shoulder replacement that we have to look out for. It goes to your deltoid muscle, and that's going to be an important muscle to move your shoulder. So we have to look out for it and know where it's at. But all the other major nerves and blood vessels going down your arm are out of my way. We still have the issue, if we're doing a total shoulder, we have the issue with the rotator cuff. We have to make sure the rotator cuff is doing okay. And stiffness can be a problem with any shoulder surgery. So we want to get people moving as soon as we can. As soon as we can control their pain, we want to get them moving. So again, our goals of our post-op rehabilitation, move it as fast as we can for the most part. To put a total shoulder in, we have to remove one of the rotator cuffs muscles, that's the subscapularis, and we reattach it. So there's certain motions that we have to protect while that muscle heals, but otherwise we want to move you fairly rapidly. And overall, results are well into the 90% range of people that are happy, pain-free, and functioning well with total shoulder and reverse shoulder replacements. So that lets them get back to their things they want to do, whether it's sports or just working around the house, gardening, or doing what you like to do. Questions? Yes?
When you're replacing the socket joint, what do you use to keep the new material in place?
So for the total shoulder or for the reverse?
For the, well, either
So-
or. When you're, I can see where you put the stem down into the bone, but that little part up on top then, you know,
So
what's holding it there? You use a glue or something? Seriously?
yes. With Gorilla Glue. With a total shoulder replacement, the socket is plastic and it is cemented to the bone. So it's cemented in place.
Okay.
With the reverse shoulder, the ball is on the socket side now, and it had screws that were holding it in place. Plus, there's a peg, and that peg that goes down in the middle has a porous coat, and the bone grows into the pores and holds it in place. Same with the socket itself. Let's go back to a total. Let's go back to this. You don't see any cement along here. So this is a non-cemented. You can either cement this stem in place or use a porous coated stem. So the bone is actually growing into that surface and holds it in place. On the socket side, which is now the ball, you can see these screws that are holding that in place, and there's a peg. And the peg has that porous coat where the bone grows into it and holds it in place. So how they're held in place, either cement or the porous coat.
So, do you need to stimulate with some additive the bone growth?
No, the bone will heal it.
It'll go by itself?
Well, so when we first look at that socket, it has that worn out white cartilage that's there still. We ream that away, so now we're down to a bony surface that has a good potential to heal into the back of that. So we do prepare it, but no, we don't add anything.
And much of what you're saying about the shoulder applies to other, like a
Yes.
total hip replacement.
So hip
Which
replacement,
are
you can
pads.
cement or porous coat. And same with the knee, you can do cement or a non-cemented knee. For those different applications, like at the knee, more than 90% are cemented. So that's, the vast majority are cemented. At the hip, the vast majority are uncemented. They have different advantages.
So if you had to redo that sometime in the future, say because of an infection or something, and you got that bone all growing through there, how do you take that out then? You got a lot of shearing and grinding to do, or what?
Yes, so that's tricky. So especially if you have if it's cemented, you also have a cement mantle around that. And so if we're looking down where this, we want to take this stem out, we don't want to break up the bone. We want to maintain this sleeve of bone. Sometimes we have to create a window here and tap it out, okay? Or we have osteotomes, which are chisels that are flexible, and they go right along the edge here. So right along the edge of the prosthesis to loosen it, then you can grab it and pull it out. But it's a tedious process. You don't want to be too aggressive with it because you'll break this bone and then you're left with a tough reconstruction in it. So you want to maintain that sleeve of bone. So reconstructions are difficult.
One of the side effects of taking statins for many years is supposed to be muscle soreness.
Muscle soreness, but I don't
Shoulder.
think they affect the joint itself. And I don't know if we really know the etiology, the cause of that muscle soreness.
I asked my cardiologist, he checked me over, and he said, "No, you're just having too many birthdays."
I'm one of those guys that has been fighting with my doctor about statins. I didn't want to go on one yet, and I just had my blood work done this week, so I'm going to see what it is. But I'm trying to avoid it.
Well, I've been on it for 28 years, so.
Yeah, they're great drugs, but they do have side effects of that, achiness, and but they don't really cause joint deterioration. They cause this muscle achiness.
When I was a young man, way back in the last century, in fact, I was in the Army when I was 20 years old. I'm laying in my cot one day, flailed back like this, and the sergeant walks by and says, "Boy, you sleep like that and you have shoulder problems later." Is it true? And why? And then what is the optimum position to have your arm when you are sleeping?
I would say that the sleeping position does not cause shoulder problems, but I will tell you, almost universally, people will complain of shoulder pain at night. Oh yeah, it hurts when I raise my arm up, it hurts, but I can't get to sleep because I lay on that side, it hurts, or I lay on my stomach and I put my arms up and it hurts, or I lay on my back and it rolls my shoulders back and it hurts. A lot of people complain predominantly of night pain. So it's more the position, it's aggravating it, but is it causing the pain? I don't think so.
You talked with the reverse shoulder replacement a couple of times about a non-functioning rotator cuff. So once it heals, if it's a non-functioning rotator cuff, would you have complete range of motion and all that?
They have pretty good motion. So with shoulder replacements in general, do we see dramatic improvement in your motion? No. So some people, I can raise my arm up to here and it hurts. After shoulder plate replacement, they can raise your shoulder up to here. They don't get this again, but now they can go to here without pain. That makes a big difference. If you can get to here, you can grab something on a shelf, you can wash your hair, you can do normal things. So you get a functional motion. You don't necessarily get full motion back. Again, the reverse keeps the ball and socket together versus if you have the traditional total shoulder, without a rotator cuff, the ball can slide up. And that doesn't work as well. If you have it the other way, it holds it in place. Even without a rotator cuff, the bigger muscle, your deltoid, can work. And so that's really important to have a functioning deltoid. That's why I mentioned that little nerve that we have to look out for, the axillary nerve. If you inadvertently injure the axillary nerve and you have a reverse shoulder, you really don't have a good way to raise your arm up. You're relying on that deltoid. So you really got to look out for that nerve.
Yeah. Doctor, I was told that for a longitudinal rotator cuff tear, that surgery is not as effective. Can you comment on that?
Longitudinal tears are not, you mean in line with the fibers of the muscle?
That's correct, yes, sir.
So, not real common.
Mhm.
You can see splits there, but not very common. Sometimes you'll see, the picture I showed you was kind of almost like a U-shaped tear, which is pretty common. Sometimes they're L-shaped or they're different configurations to the tear. And that just changes just how we repair them, how we tack them back in place. You didn't ask me about the nuts and bolts of fixing a rotator cuff. We're repairing something, a tendon to back down to bone. How do you sew something to bone? We use suture anchors. A suture anchor, just like it says, is an anchor that goes into the bone that has sutures coming out now. And we can use those sutures to sew the tendon back into place. So that we typically use those. But a longitudinal tear should not be something that's a problem. Yes?
No pain at all, but lack of strength in throwing a ball or shooting a basketball. Is that have to be a shoulder thing, or is that something else? And what exercises would be effective in dealing with that?
I'll make two comments about that. First of all, there are some people who have massive rotator cuff tears. I can't raise my arm up, but no pain. And you can have a partial tear that people having a lot of pain. So number one, the degree of the pain is not indicative of the size of the tear. Some people tolerate large rotator cuff tears without problems. Secondly, you could have a problem with the nerve going to the rotator cuff, either at your neck or there's a little place where the nerve can get pinched, and now the nerve nut, the muscle isn't getting the signal, and it can give you that weakness. So it can be neurologic. Some people just have weakness and don't have a lot of pain.
Can you explain what having loose upper body joints means, and then what is the potential impact or possibility of injuring the upper body?
So laxity or loose joints. Some people just have relatively loose joints. Their collagen is a little looser. If you watch those Olympic swimmers warm up and they're stretching and they're doing all these crazy things, or if you watch a baseball pitcher, remember that picture I showed you of that baseball? This form is below parallel here. They have incredible flexibility. So that flexibility can actually allow you to be a pretty good athlete, but it can also be a problem where the ball wants to move around in there, and cause instability problems. We didn't talk about that at all. You can cause labral tears, you can cause rotator cuff tears, you can cause biceps tears from having the ball too loose in there. And of all the joints in our body, the shoulder has the best range of motion of any joint. So it has the problem with an instability the most. So where the ball wants to move around too much. And that's usually a younger person's problem.
Could you comment on scar tissue and its interplay with the partial tear?
So with any shoulder problem, say you have this partial tear and your body's response was trying to heal that partial tear. For some people, that response can be very abundant, and it really creates a lot of scar tissue, something we call adhesive capsulitis, better name for it, frozen shoulder. It doesn't move at all. So that could be initiated by a lot of different things, sometimes by rotator cuff problems, where they have tendonitis or partial tear, and that the body just has this abundant response to it. So you want to have some scar tissue to help heal that rotator cuff, but you want it not to be all over the capsule or the joint. Does that answer your question?
Okay, for more questions, call the Virginia Orthopedic and Spine. And ask for Michelle, and you won't have to wait long. She drove all the way up from Charlottesville this morning.
Thank you.
Yeah, I'm